25.8 million. Yeah, that is not a typo. That's the staggering number of people in the United States alone who are currently living with diabetes. To put that into perspective, you're looking at over 8% of the entire population facing this chronic daily health challenge. And honestly, the wildest part of this statistic, up to 95% of these cases are type 2, which is a condition heavily tied to our environment and lifestyle. Welcome to this explainer, where we're going to pop the hood on the human body to understand exactly what goes wrong when this disease takes hold.
So, think of your body as this incredibly complex, finely tuned engine. For this engine to run, it needs fuel, which in our bodies is glucose. But glucose can't just float around freely in your bloodstream and do its job. It actually needs to get inside your cells to power them. Insulin is essentially the key that unlocks those cellular doors, allowing the glucose fuel to enter. Diabetes mellitus is, quite simply, a mechanical breakdown of this exact key and lock system. Today, we're diving deep into the mechanics of this metabolic breakdown, uncovering exactly how this system fails and what it actually means for the patient.
All right, here's our roadmap for today. Section 1, Decoding Diabetes Mellitus. Section 2, Type 1 versus Type 2. Section 3, Spotting the Symptoms. Section 4, Diagnosing the Disease. And finally, Section 5, Treatment and Complications.
Section 1. Decoding Diabetes Mellitus.
Okay, let's unpack this definition. Diabetes mellitus is a chronic metabolic disorder, and its absolute hallmark is chronic hyperglycemia, which is really just the medical term for persistently high blood sugar. Now, there are 4 primary mechanical failures that cause this massive glucose traffic jam in the blood. First, it can be due to an absolute lack of insulin, meaning the keys are entirely missing. Second, it can be due to impaired insulin secretion, so not enough keys are being manufactured. Third, you've got insulin resistance, where the keys are perfectly fine, but the locks on the cells are totally jammed. Or fourth, it can be increased glucose production, where the liver is just going rogue and pumping out way too much fuel.
Section 2. Type 1 versus Type 2. In type 1 diabetes, it's essentially an inside job. The body's own immune system, specifically the T lymphocytes, mistakenly targets and destroys the beta cells in the pancreas. And remember, these beta cells are the factories that produce insulin. Because these factories are completely wiped out, the patient is left with an absolute lack of insulin. Without any keys whatsoever, glucose is locked out of the cells and blood sugar just spikes. Because of this absolute deficiency, people with type 1 absolutely require outside help. They have to take daily insulin just to survive and stop the body from cannibalizing its own tissues for energy. Now flip the script for type 2 diabetes. This is a stark contrast. There is absolutely no autoimmune attack happening here. Instead, type 2 is driven by a combination of genetic predisposition and environmental factors, most notably obesity. In this scenario, the pancreas might actually be pumping out plenty of insulin, but the tissues, especially the muscle, liver, and fat, have developed insulin resistance. The locks are jammed tight. And to make matters worse, the liver starts increasing its glucose output. So you end up with a highly resistant body paired with even more sugar flooding the system. It's a perfect storm.
Let's quickly summarize the clinical differences between these two pillars, because the profiles of these patients look very, very different. Type 1 usually has an abrupt onset in younger people, and it's often accompanied by sudden weight loss because the starving cells are literally forced to break down body fat for energy. Their circulating insulin is, of course, markedly reduced. Type 2, on the other hand, is much more gradual. It usually appears in adults, over 30, though, honestly, that's changing with rising childhood obesity. These patients are often overweight, and crucially, their circulating insulin levels might actually be elevated or normal initially, as the pancreas desperately tries to pump out extra keys to overcome that cellular resistance.
Section 3. Spotting the Symptoms. So these internal cellular failures build up into what medical professionals call the classic 3 polys. When blood glucose gets incredibly high, the kidneys just can't reabsorb it all. The excess glucose spills over into the urine, and it acts like a massive chemical sponge. It literally pulls huge amounts of water out of the body along with it. This causes polyuria or excessive urination. Now, because the body is suddenly losing so much water, it triggers severe intracellular dehydration, leading to polydipsia, which is excessive thirst. Finally, because the glucose can't get into the cells to actually provide energy, the cells are literally starving, triggering polyphagia, or excessive hunger. Beyond those 3 polys, these systemic symptoms basically map across the entire human body. You'll see blurred vision, which happens because the lens of the eye is physically exposed to those hyperosmolar sugary fluids. You'll also see severe fatigue. since the body's primary energy supply is totally cut off. And take a close look at the symptoms that are more common in type 1, specifically that rapid weight loss and a distinct smell of acetone on the breath. Yeah, it actually smells a bit like nail polish remover. That's a byproduct of the body rapidly burning fat for fuel because it has absolutely no insulin to utilize sugar, which leads to a highly dangerous state called ketoacidosis.
Section 4. Diagnosing the disease. Okay, let's talk hard numbers. When we look at fasting plasma glucose, a normal fasting level is under 100 milligrams per deciliter. A formal diagnosis of diabetes mellitus is made when that fasting level hits 126 or higher. But I want you to pay special attention to the pre-diabetes stage, where glucose sits right between 100 and 125. This is absolutely critical. There are 79 million people sitting in this middle category. Recognizing this phase is huge because with interventions like simple calorie reduction and increased physical activity, patients can actually halt the progression to type 2 diabetes before the engine completely breaks down.
We also need to briefly touch on a very specific, temporary form of this metabolic breakdown, gestational diabetes mellitus, which affects about 7% of all pregnancies. Because of the incredible metabolic demands that pregnancy puts on the body, some women develop glucose intolerance. We typically screen for this using a 75-gram oral glucose tolerance test between 24 and 28 weeks. Precise maternal glucose monitoring is absolutely essential here. Why? Because even mild, uncontrolled high blood sugar can lead to severe fetal abnormalities. Things like macrosomia, which is where the baby grows to an abnormally large birth weight, as well as dangerous, rapid drops in the baby's own blood sugar right after birth.
Section 5. Treatment and complications.
Managing this disease is a relentless daily reality for millions of people. It requires constant capillary blood glucose monitoring just to maintain near normal levels. We're talking about using a small lancet to test a drop of blood multiple times a single day. But it's an incredibly delicate balancing act. If a patient takes too much insulin or medication relative to their food intake, they risk hypoglycemia. That's dangerously low blood sugar, which triggers intense trembling, a pounding heart, heavy sweating, and severe confusion. It requires constant, active management to keep those fuel levels perfectly in the sweet spot.
Now, for type 2 diabetes, because the breakdown is so multifaceted, the treatment has to be multifaceted as well. We can't just rely on replacing insulin like we do with type 1. The first line of defense is always lifestyle management and weight loss, but when drugs are needed, they literally target different parts of this broken system. Some medications decrease glucose absorption right in the gut. Others, like biguanides, tell the liver to stop pumping out so much extra glucose. And then others target the muscle and fat tissues directly to increase peripheral glucose uptake, essentially forcing those jammed cellular locks to turn.
So why are we so intense about managing this? Because chronic hyperglycemia essentially acts like a corrosive acid in the bloodstream. Over time, it destroys blood vessels. It leads to devastating microvascular complications like retinopathy, which literally causes blindness, nephropathy, which leads to total kidney failure, and neuropathy, causing severe nerve damage that often leads to foot amputations. And if that wasn't enough, it also drives massive macrovascular complications, significantly increasing the risk of strokes in the brain and severe coronary heart disease. It truly affects the whole shebang.
We've seen exactly how the lock and key system fails, how it manifests as symptoms across the body, and the truly devastating damage it can cause if it's left unchecked. But think back to those 79 million people currently in the prediabetes phase. Knowing the precise mechanics of this metabolic breakdown, how can early intervention, things like diet, exercise, and weight management, completely rewrite a patient's entire physiological future before the damage becomes permanent? It's a powerful reminder that while the mechanics of diabetes are incredibly complex, the opportunity to change the course of the disease is still very much in our hands. Thanks for tuning into this explainer, and keep learning.